So sometimes when you walk into a room, your patient's alarm may not be ventilating, but you can look at your patient and know that they're having distress. You'll see the patient is diaphoretic, they'll be nasal flaring, have increased effort to breathe, their eyes will be wide and they'll be staring at you like something is wrong even though no alarms are going off. It's important to assess your patient and an overall appearance. Cyanosis may not be a reliable physical sign as it usually comes later in the process. Tachypnea, tracheal tugging, intercostal retractions, sitting up in a tripod position, paradoxical movement of the patient, just an overall general appearance of being air hungry and needing to breathe can be a very early sign that something is going to go wrong and your ventilator may be performing. Some of the potential ventilator alarms that can go off, and we will go over these in much more detail as the lecture goes on, are high and low pressures, high and low PEEP, apnea, inverse IE ratio, high and low tidal volumes, high and low minute volumes, and high and low respiratory rates. And we're going to talk about those more in specific detail now. So our first ventilator alarm that could go off would be possibly would be a high tidal volume, high minute ventilation, or high respiratory rate alarm. So the first thing you need to think about is, what did I do? What could be possibly causing these symptoms in the patient? Is the patient air hungry? They're not getting enough breaths? Are they in pain or agitated? Did you just perform a procedure on the patient and they're trying to get more air in because they're suddenly tachypnic because they don't feel well or they're afraid of what's going on? Is there water in the tube? That could be making the ventilator think that the patient's taking more breaths than they actually are in a minute. So all those are things